Hi, everybody. Thank you so much for joining our first annual community lecture here at Providence Hospital. My name is Brandon Evans, and I will be the moderator here for this evening's lecture. Thank you. I just want to thank everybody for joining. I know we have our work cut out this evening. We have two experts in the field of psychiatry and chemical dependency recovery, so I can't wait to get going. So good evening. Thank you so much for joining us. Joining us for our virtual community lecture focusing on addiction and mental health. Like I said, my name is Brandon. I'll be the moderator for this evening's lecture. We are joined by two experts today, Dr. Pisano and Dr. Harman. Before we get started, I want to let everyone know that this is a 1 hour long presentation, and we will have plenty of time for questions at the end of the presentations. Please use the Q&A box to type any questions you have throughout the event, and we will do our best to answer each question at the end of the presentation. We will not be opening it up for the attendees to speak on the webinar. Before I introduce the first presenter, I just wanted to share a bit about our behavioral health programs here at Providence. So we have several here at Providence. Our first one that we're going to be, Dr. Harmon will be shedding more light on, is our OPHC, which stands for the Outpatient Behavioral Health Center. And so that's one of our newer units here at Providence. That unit specializes in 24-hour emergent psychiatric treatment. And then our other unit, which we'll be talking about tonight, this evening, and Dr. Pisano will go more into details, is our Providences Recovery Center, formerly known as the Chemical Dependency Unit here at Providence. That unit specializes in detoxification at a hospital level, along with our rehab unit. So for those folks struggling with any sort of substance abuse problems, they can come in and get expert treatment and see Dr. Pisano, who will be the head physician there. Perfect. Okay, so we're going to actually start with Dr. Pisano, who's going to be talking more. So here's his quick bio. Dr. Pisano has been the primary care and internal medicine physician in the hometown of San Pedro since 1982. In addition, he is currently the medical director of Providence Recovery Center. Dr. Pisano has also served as chief of staff here at Little Company Mary Medical Center, the hospital where he has been born on Christmas Day and now practices in. Fluent in Italian and Spanish, Dr. Pisano can provide best in primary care to the community he serves and has been able to provide help to some of our most vulnerable substance-dependent patients. Now a senior member of Providence staff, he enjoys a full active practice and he has the vigor and energy to continue to serve his community. Like most San Pedrans, he enjoys his family, his Italian and San Pedro roots, and still has time to hone his skills in as an accomplished chef. Without any further ado, here is Dr. Pisano to take over. Thank you so much.
Okay, thank you, Brandon. 2020, in a sense, was a very difficult year for everybody. It was kind of a lost year, and for people who struggle with addiction and mental health problems, it was a year that brought new issues. Now, like Brandon said, my part of the lecture is going to be the horseless carriage part of the lecture. I remember as a young doctor starting out, I thought, oh, geez, when I become a big time doctor, I'm going to have slides and I'm going to do a presentation and it's going to be so great. Well, about 35 or 36 years later, I think my 7-year-old grandson can do a better PowerPoint presentation than I can. And so, you know, my part of the lecture is going to be the horseless carriage. So I'm going to take you on a walking tour through recovery. And then Dr. Harmon, on the other hand, is going to use the high tech. You're going to get the Tesla when he talks about addiction and behavioral health issues. So the first thing that I'd like to do is tell you a little bit about Brandon has kind of told you, he kind of read that bio that, geez, you guys share things. I just kind of made that up the other day and somebody in marketing, and then stuff travels fast. But if you'd have told me in 1984, when I joined the recovery center, that this part of my practice would be more rewarding and be more impactful than being a primary care physician, I probably would have told you you're nuts. But in reality, the program that I'm lucky to have been affiliated with, that's the Recovery Center at Providence Little Company of Mary San Pedro Hospital, has probably saved more lives than what I do in my day-to-day care of patients. So the Recovery Center has been here since 1975, which is a long time. I've been the medical director since 1984. I guess the only time I like being described as a senior is when I get a discount. So I was a little kind of I still think myself as the young person on the staff. But today, I think everybody who's here is here because either personally in their lives, whether through addiction or being related or living with someone who is an addict, or being a care person who is trying to get these people help, is that all of the people here are vested in somehow or another dealing with a problem that's very difficult to deal with. Now, we've got to realize that addiction, if you were to define addiction, the very simplest definition of addiction would be it involves repeated use despite adverse consequences. So what does that mean? You keep doing the same thing over and over again unless in spite of bad things happening. So that's how we can define drugs as being addictive. That's how we can find behaviors as being addictive, such as sexual addiction or addictions to food addiction. And we got to realize that no one does things to feel bad. Every addict or alcoholic is basically doing something that makes them feel better. And the other thing that I'd like people to realize is that myself, I am not very influential, important, and I don't have the cure or a treatment for addiction or alcoholism. But you can be part of a team. So it's very difficult to walk this path alone. The fortunate thing is that I work with a bunch of professionals that have been very dedicated. They're dedicated to the people that they serve. And what we got to realize that addiction utilizes a healing community. And without that healing community, it's very difficult to do this thing alone. So why do people keep using drugs? There are three. The main reason people keep using drugs is they want to feel good. And that feel good chemical of your brain is something called dopamine. And dopamine, which we usually think of as a stimulant chemical, is very important. And it's involved in all the drugs of abuse, whether it be a stimulant drug. The stimulant drugs are the drugs that we know as stimulants, principally cocaine and methamphetamine. But it's also involved in the relaxant drugs. So there are amino acids in your brain that help your brain and body to relax. And those amino acids are derivatives of amino acid called GABA, or gamma aminobutyric acid. The drugs that affect that, the number one drug would be alcohol. A lot of the benzodiazepines. What are benzodiazepines? The tranquilizers, the relaxants like Valium, Librium, Xanax, Klonopin, all of those drugs. And then the last class of medications that I like to talk about are opiates. And opiates are those chemicals that affect the pain mechanism in your brain. And it's really very interesting because no matter which one of these three different classes of drugs that we're talking about, directly or indirectly, they involve the use of dopamine. So what is powerlessness? So one of the things that we talk about a lot in addiction is powerlessness. And to me, powerlessness is a concept that came from the 12-step community, which has been around for probably, I know I'm bad with numbers, but I think it's been around for 75 years. So it kind of happened kind of during the Depression or right after the Depression. And basically they came up with the concept that you are powerless over your drug use. But what does that actually mean? What does powerless actually mean? What powerless actually means is that your brain chemistry is altered by the reduction in not only the neurotransmitters that are very important in your brain function, like dopamine, like the amino acids that help you relax, like the drugs that if they're altered or depressed cause depression, or alterations of dopamine can cause psychosis, that the use of chemicals sets up a reaction where those brain chemicals are depleted. And when those brain chemicals are depleted, the disease of addiction develops. And the reason people keep using is because their brain doesn't want to work. So it's like your car. So when you have a car, and I'm not a mechanic, so this is like the only tool, the only analogy that I use. And it's happened to me, I've used this battery analogy, and kind of, I used it so often that I think both my Alter and battery gave out kind of about several years ago. But your brain is like a battery where its energies and the neurotransmitters are stored. When you use drugs, basically what happens when you go to turn on your car, you have, or when you go to use your brain and turn on your brain to use what it has to do, is you have that stored energy that's there in the form of dopamine and a balance of all these amino acids and neurotransmitters. You start your car by turning on the ignition. Your car starts, and then you drive it around, you stop it. And when you come back, what happens is that with the stimulant drugs and all the drugs, is they impair the body's ability to reuptake dopamine. What does that mean? That means if you drive your car, and we've all experienced this, you have a dead battery, you replace the battery, you go to start it, you drive it around, it's fine, you park it, you come back a half hour later, you go to start the car and your battery is dead. So you call the guy out from AAA. Usually AAA is really good about it, because they actually check your alternator before that. But they tell you there's this magical device called the alternator that doesn't work. So basically what the body's alternator is the reuptake or recycling medicine to take those neurotransmitters that once they use, they put them back in your brain. So so what do we do at the Recovery Center? Basically at the Recovery Center, we provide the ability to safely have people begin and continue the journey in recovery. The journey in recovery usually starts with detox. There's no magic to detox. Some of the drugs that we use now, especially the stimulant drugs, the reality is we don't have really great detoxes for them. We do have medications that help prevent the complications of withdrawal. They're most significant in the alcohol withdrawal. And so we give people medications to help relieve the symptoms of withdrawal and safely transition them into the next phases of recovery. And the next phases of recovery are usually stabilization, and addiction is a long-term process, and it takes time. So what is the most addictive drug that people have to deal with? The most addictive drug that people have to deal with is actually nicotine. And why is nicotine so addictive? A smoker, when you use nicotine, it gets inhaled very rapidly through your lungs. It goes to your brain. It causes the release of that magical chemical called dopamine. And what does dopamine do? Dopamine makes your brain work better. It makes you function clearly, and it allows your brain to do things in a rapid sequential way. So if you're a smoker, what happens when you try to stop smoking? When you try to stop smoking, 90% of people who attempt to stop smoking relapse. That percentage is the exact same percentage and relapse rate that opiate addicts have when they attempt to stop using opiates. And the reason is because that dopamine is depleted, doesn't get regenerated, and the way you regenerate that substance, the only way is to remove the substance and allow the body to regenerate. But most people cannot do that, and that's why they go back to smoking cigarettes. That's why they go back to using opiates. So that period of vulnerability, how long is that period of vulnerability? Significant others who are affected by the disease of addiction. How do you define the disease of addiction? You define the disease of addiction by negative consequences. And what are negative consequences? Because the most common thing that I see or that I hear from patients is that I don't really have a problem. It's not significantly impacting my life. And some people think they are high functioning addicts or high functioning alcoholics. But addiction is defined by any negative or adverse consequence. So if you're a parent and you're drinking or using and you're not there for your child for whatever reason, that's a negative consequence. If you have absenteeism or you have poor job performance, that's a negative consequence. So it doesn't always have to mean that you have issues with your liver, that you have issues with your heart. All those things can occur. So what about specific drugs? So I think alcohol has been around forever. Alcohol in its beginning, most people use it as a stimulant. How can it be a stimulant if it depletes your brain? Well, initially it causes the release of dopamine. So initially you feel that energy, that positive surge from drinking. That's replaced with time because you deplete your neurotransmitters of not only dopamine, but the other neurotransmitters that are important to keep you healthy and going, is that it also causes imbalances in your other brain chemicals. So after a while, it no longer acts as a stimulant, it acts as a mood stabilizer. So it acts to help you sleep, it acts to help you deal with depression. And in very high amounts, we know that alcohol can be toxic. So in high amounts, it acts like an opiate. So it causes, coma, it can cause death, it can cause a lot of those things. So alcohol really can be any of the drugs. Now the stimulant drugs kind of are a little more simpler to think of. So the stimulant drugs principally are cocaine and methamphetamine. The big problem that we have in our community is that methamphetamine, which in a sense is time-released cocaine. So it's a stimulant drug. It causes the immediate release of dopamine, but it tends to hit multiple dopamine receptors. And I'm sure that Dr. Harmon will talk about this when he gets to his part of the lecture, is that a lot of the people that we see in, San Pedro has always been a very welcoming community. We've been a community of acceptance and tolerance, I think because of the different ethnicities of this community, because of the cultural aspect of this community. We've always had sober living homes. We've always been very receptive to people who have other issues. But, you can look in our town now has been, the homeless crisis that we're seeing, the major reason behind the homeless crisis that we're receiving is not only the use of opiates, not only the use of alcohol, but I really think the negative consequences of the uses of amphetamines, because amphetamines drain that part of dopamine. And dopamine is not just a very simple receptor. And a lot of the drugs that we use to help people deal with changes in their perception of reality are based on dopamine receptors. And the overstimulation and depletion of those dopamine receptors caused by methamphetamine is a lot of the reason why you see people refusing housing and rather live on the streets, just so they can use that money to have drugs. So enough about the negative stuff. Now, what is the positive stuff about recovery? The positive stuff about recovery is that in 36 years of, it's more, sorry. Going on my 38th year. I got to do the math. I was a whiz at math, but I guess getting old makes your math a lot more difficult. So This July will be the 38th year that I'm doing this job. Has it changed much in the past 38 years? Yes and no. I think the yes part that it has changed is that the positive is that there is more acceptance of drug addiction and chemical dependency. But I think what we've seen in this past year is that people have not, and our census and the amount of people that we treated in 2020 diminished probably by a good 30 to 40% for multiple reasons. One is people who normally would seek treatment didn't for a lot of the social reasons, period, in that they were worried about their employment, they were worried about their insurance, they were worried about a lot of other things. And that denial was an issue. We also saw that people use substances, and the substance use went up, addictions went up, overdoses went up. Now, I'm not going to really talk about the specific opiates that we're dealing with, but one of the big changes, being a port town here in San Pedro, we were always a portal for entry for opiates, for heroin. The problem is that in this internet world and society, there's a very potent drug called fentanyl. And fentanyl is a drug that is synthetic and is much more potent than heroin, and very small, tiny amounts can cause significant overdosage and even death. And one of the issues that we've seen in the past several years, and especially in the past year, is that people have unintentionally or intentionally overdosed on fentanyl, either accidentally or because their normal supply of what they thought was heroin was actually cut with a more potent substance. So how long does it take to recover? Recovery is a lifelong process. It takes definitely weeks to months to, most data show that it takes a minimum of 2 years to allow your brain to recharge itself. So during that time, what does a patient need to do? They need the help of others. The 12-step community, for years, we in the recovering community always felt that the 12-step were the most important thing. And now we have data to show that one of the most important factors in a person's recovery is not whether they went to a hospital-based program, whether they went to inpatient, outpatient, community, is actually the number of self-help 12-step meetings they attended in their first year of sobriety is probably one of the most significant factors in a person's recovery. So one of the goals that we have at the Recovery Center at San Pedro is to basically, number one, get people to work on their first step, which the first step is that you admit that you're powerless over drugs and alcohol. Very simple concept. Powerlessness, acceptance, simple but very hard. And because powerless means that your brain lacks the chemistry and the fuel that it needs to run right, that leads to your constant relapse. So we try to provide them a basis of one, acceptance, forgiving themselves, and mending the things that they've done. And one of the big problems that we see in recovery is people always want things to happen faster than they naturally happen, because families may take time before they accept a person who is in recovery. That person in recovery thinks, I'm fine. Why doesn't everybody else around me think that I'm fine? So recovery is a lifelong process. Recovery is difficult, but it's something that when a person embraces and accepts their addiction and embraces their addiction and becomes honest. So one of the keys that we talk about in recovery is you have to be honest. You have to be honest with everybody around you. First of all, you have to be honest with yourself. You have to be honest with the people taking care of you. So that's admitting that you're an alcoholic and addict. And people still struggle with that and feel guilty with that. And I see that when they come back and see me in my office. They say I look different in my office uniform rather than my uniform that I wear over at the Recovery Center. So there's still a stigma. I think we need to work on that stigma. So in summary, I think that recovery, and when a person seeks recovery, number one, realize that relapse is common. It usually takes people at least more than once to try to get recovery. It can take up to 4 or 5 times, and relapse rates are high. But, you know, if you look at other diseases, and we're trying to get people to accept addiction as a disease, but I think we've gone so far out to the right or the left, or I forget which side is which, that people still think it's their fault or it's something they can control. But, you know, we're working on that. You know, what you can control is the people, places, and person that you're around, and those have to change. And unless they change, people don't get better. Now, so what I'd like to do is just kind of stop there. If there are any questions, I think that probably the moderator will ask you to hold them till the end. And I hope you like my walking tour, because you guys are going to get the Lexus from Dr. Harmon, because he's a whiz on PowerPoint, and it's what I thought I should do. But being an old guy who still has his hair, I'm kind of like talking to people and like connecting to people, because I think the key that we do at the Recovery Center is, number one, get people to connect with themselves, connect with their feelings. And once they do that, the process of recovery, which is an ongoing, lifelong process, can continue. So I'm looking forward to your questions at the end, and I'll turn this over to Brandon now.
Beautiful job, Dr. Pisano. Geez, thank you so much. And I just want to add real quick for the group, if you or your loved one or a family member, anyone is struggling with any sort of addiction issue, we're going to go ahead and post in the chat our website web address, along with our intake line. So we do have a 24/7 intake line that is available. We have counselors on standby who could just kind of walk you through the process. They can help answer questions. Obviously, we're the experts in that. You know, I have the ability to actually work with Dr. Pisano, and such a blessing to be able to work with the staff down there. They're just tender, loving, caring staff that actually have lived experience, and they're not just doing it for a paycheck. They really are. Their heart is in recovery, and that whole unit just provides a beautiful, beautiful experience in a not so good situation. So I encourage you guys to reach out. Like I said, we will put our intake line for our chemical dependency unit in the chat, along with our website. So feel free to just click on the link, explore around on the website, and if you have questions, call us personally. We can definitely help answer those questions. And if for some reason we can't accept your loved one into our specific program, we will work with you to find the appropriate place. But thank you so much. Very good. So without any further ado, we will go ahead and jump into Dr. Harmon. Harmon, thank you so much. Dr. Harmon is our Regional Director of Acute Psychiatry for Vituity. In this role, he is responsible for developing Vituity's acute psychiatry services, including inpatient psychiatry, telepsychiatry, and crisis stabilization. Dr. Harmon served as a psychiatrist in the United States Air Force, which led to the deployment to Afghanistan, where he was a combat operational stress control officer. Since his return from Afghanistan, Dr. Harmon has dedicated his career to offering psychiatric evaluations in the emergency room setting and serving as a medical director for our outpatient psychiatric and brain stimulation service. Dr. Harmon offers more than 15 years of experience in inpatient and outpatient and emergency care settings. His philosophy is to help patients quickly get to the setting that promotes recovery while ensuring safety from imminent dangerous situations. Dr. Harmon received his medical degree from the University of Virginia in Charlottesville and trained at the University of Pittsburgh Medical Center, which he was the chief resident. He is currently working towards his Master of Business and Admin at UCLA Anderson School of Management with an expected graduation date of June 2021. Without any further ado, let's welcome Dr. Dr. Harmon. Thank you so much.
Thanks, Brandon. Graduation was last week, so I got that done with. So hello, everyone. I hope you can hear and see me fine. It's a pleasure to be here. I'm very appreciative of Brandon and everyone at Providence San Pedro for inviting me. It's a place it's kind of become home base. The partnership I'm with is national. We're all over the country and hundreds of hospitals. We have thousands of doctors, but my clinical home has been the OBHC San Pedro right there, where I've taken turn as a medical director there. A lot of docs have joined us to work at helping folks. It's been almost 4 years now, so I've gotten to know everybody pretty well, and it's an amazing opportunity to help so many people surrounded by such skill with nursing care and social workers, everybody. So maybe I could start off by just explaining a little bit about what the program is. The outpatient center is so called because it's essentially an extension of the emergency room for folks who are not well enough to wait for an outpatient appointment and require a psychiatric evaluation sooner. And they're sitting in emergency rooms, including emergency rooms in the Providence network, that might benefit from up to 24 hours of observation, evaluation, stabilization, treatment, resources. The emergency rooms can present us information. We can take a look at it and see, is this somebody that looks like we could possibly help? And there's so many people we're able to help and just pull them in. And it's a unit that allows freedom of movement and access to nursing care immediately, access to psychiatrists within an hour, and access to social work within the end of a shift. And about 70 to 80% of folks we see we're able to help stabilize and return to their home or their community or a recovery program or something other than a locked inpatient unit. And then for folks who are needing additional services, we just help them by helping facilitate the transfer for that kind of service. There's been a few news articles about the unit. There was one that was written by Kaiser Health News actually and published, actually is put out, CNN picked it up. And so this is actually a picture of the unit. You can see there that this was in a lot of national publications as they were describing what we're trying to accomplish, something other than typical urgent care psychiatric services, and also not just waiting for an outpatient appointment. It's not a walk-in center, so it's the kind of thing that for folks who would need to be seen in an emergency room first, if we have room, we're able to accept referrals from emergency rooms. So you can see the open space, the chairs, it's a comfortable setting. It's the kind of place where people can really, I should say, I guess what I mean to say is it's much more calm and inviting than an emergency room, medical emergency room, where people could be coming in with heart attacks and strokes and whatever. We kind of help pull them out of that environment. So I'll just highlight a few things that to add to what Dr. Pisano was saying. I want to think about where we are now, where we've come from, say, 2019. There's so much talk about that. And I think it's best to just kind of step way back and take a look at the data and ask ourselves, is what we think we're seeing actually what we're seeing? So in summer of 2019, approximately 1 in 10 or 11% of folks polled in America had significant symptoms of depression and anxiety. It's actually a pretty high number. If you look at the number one cause of disability in almost every study, it's depression in terms of folks who are of working age, like 18 to 70 or 18 to 65, depending on which study you're looking at. It's about this number of 1 in 10 includes a lot of people who are actually disabled by depression and anxiety. So it's pretty remarkable, and it's very important to have that top of mind as we're thinking of our health. Mental health is health. It's not a separate thing. There's not really medical health and mental health. They're all the same thing. The brain's made up of a bunch of neurons, as we were just hearing about, and it's just as vulnerable, if not more vulnerable, than the other organs in our body to disease process or just malfunctioning or need for rest and recovery or treatment. So summer 2020, let's fast forward now. Same poll, same way of looking at things. The increase was phenomenal, 3 times, 31%, right? So we don't have data for this summer, But you get the idea. I'll be really interested to see how things change in the near future. So COVID changed so many things. Everyone, of course, is talking about the lockdown, but there was also a lot of fear. There were a number of people who saw loved ones die. And then the economic shakeup, right? So there are so many people who either lost work and are still looking, or gave up and they fell out of the market, right? So they're not even trying anymore. Income inequality is a major problem, homelessness, and as we just heard, substance dependence. So now more than ever, literally, I mean, people say that all the time. Now more than ever, we have to worry about our mental health, but there's actually data to suggest that that's like doubly true now, and I guess like triply true now. So that's a thing. So here's another way to look at it. This is presenting some of the same data, and it's giving you a little bit of a reference down there about where you can pull this information up. During late June, 40% of U.S. adults reported struggling with mental health or substance abuse. So you can see trauma-related symptoms, 26%, 13% started or increased substance abuse, and 11% seriously considered suicide. So some of these overlap, but not all of them. So it's a pretty high number of folks. Here's another look. Cook County, you're looking at Chicago, Illinois. That line shows you when the lockdown started, and the purple is probable overdose pending toxicology reports. The greenish blue is known overdoses. So pretty clear that there were problems with people overdosing once people were all stuck home. That could be for all kinds of reasons. People losing access to some drug that they were using or abusing, and then all of a sudden getting it back spontaneously and not having tolerance anymore. It could be that we're becoming more depressed because of the lockdown or because of losing your job. We're not, I guess at this point, it doesn't really matter so much other than to recognize like we kind of got all these things going on and we need to attend to them. And there was a lot of crossover too with medical problems and comorbidities with COVID and with substance abuse. So we saw mortality higher. So if all things were equal, except you had a problem with addiction and you found yourself COVID positive, there was a much greater chance that you were going to die. So instead of 6.5%, it was like 9.5. Hospitalization went up by 33%. So as you can see, there's just a ton of crossover with our mental health, our physical health. As I said before, mental health is health. So you might see in the literature some data saying, hey, we looked at it and in 2020, there weren't more suicides. So the way we're studying and measuring suicide through the CDC, that's true, there weren't. But what is also true is there were an extra 19,000 unintentional injuries leading to death. And within that pool of data includes all the people who had suspected unintentional overdoses. So if your family member died from suicide versus unintentional overdose, you're still left with the same outcome. You're wrong, right? So we want to, in many ways, we're looking at the same disease process. We're looking at the same numbers. And we don't want to be fooled by the fact that the way we're counting some things is, leaving some of this stuff out. The literature showing that more people are reporting depression, anxiety, and substance abuse, that it wouldn't make any sense if there weren't more people dying. And lo and behold, there's the extra 19,000 that we're looking for. And this is a study asking us to take a look at levels of stress, worry, and enjoyment across economic spectrums. And if you get a chance to look at that closely, you'll see it's a pretty simple story. If you're low income, you're more stressed, you're more worried, and you enjoy life less. There is a threshold at point, there's some point where you've got enough money and it doesn't make your life better. I think it's something like for a couple, it's something like $140,000 or something like that. But most people we're talking about are, that are being studied in a lot of mental health clinics are not even close to that, right? So their economic issues are significant. It's not as easy to pay rent as it used to be for maybe our parents or our grandparents. Our world is much more complex, and maintaining a job in today's environment where corporations and family businesses come and go much quicker than they used to is a real issue. So, and I bring this up because we're going to talk in a second about like, well, what should we be doing to combat these things? So causes of depression. If you go to NAMI's website, National Alliance for Mentally Ill, they list these causes: traumatic experiences, your genetics, your life circumstance, your brain changes, like maybe you had a stroke or a tumor or something, other medical conditions, diabetes, neurologic problems, heart disease, and drug and alcohol use or misuse, right? So these are the things that National Alliance for Mentally Ill says cause depression. Excuse me for the sound in the back there. I'm in a hospital. So these are what I would call the modifiable ones. So let's go ahead and take out genetics and brain changes, right? So if someone had a brain injury, there's only so much you can do. Someone has genes, their parents had symptoms of depression or schizophrenia or bipolar disorder. But these are the things we're going to focus on, what's modifiable. And so I just want to highlight some of those things for you. So if you're trying to identify in yourself what you might be wanting to prioritize or help a loved one with that, I want you to be able to think about these things. So regarding trauma, what works? Family, friends, community, psychotherapy, talk therapy, or counseling or psychotherapy, whatever phrase you're most confident to use, extremely helpful and effective for folks. Often when people are thinking about delivery of medical care, they move that to the side. It should actually be moved up to the front, right? It's one of those things where, unfortunately, direct access to psychotherapy is complex. And so often you're first leaning on family, friends, and community. So if you're trying to help someone, lean in, pull them in. There's all kinds of ways to think about doing that. I just mentioned NAMI and National Alliance for Mentally Ill. You can go to their website and find all kinds of tips and guides for how to talk to someone who might be depressed. Life circumstances, economics, housing, and safety. If you know someone who's lacking housing and safety and they have a mental health problem, and you're trying to pick between, hey, should I get them to safety first, or should I tell them to see a therapist first? Get them to safety. Without those basic things, it's really hard to accept or use any sort of kind of mental health service, even medication. Other medical conditions. Should you treat all those other things? Yes, absolutely you should. There's tons of literature how healthy sleep and exercise and diet are going to do a lot. So for mild to moderate depression, if you go head to head with a pill versus, hey, I'm changing my life, I'm going to start exercising, I'm going to start making sure I sleep, I'm going to stop drinking alcohol, I'm going to meet up with my good friends who are healthy for me. Like those things work just about as well for, again, this for mild and moderate illnesses. So we're trying to prevent things so folks don't have to end up in one of the units where I work, right? So ideally, we're so great at our job, we prevent these things, and then there's no need for these units. I think that's not realistic with populations of millions in LA County, but you get the idea. We should be trying to put ourselves out of business. And then drug and alcohol misuse, sobriety, connectedness, purpose, and meaning rather than use. These are the things that we can be focusing on. So I didn't mention a lot about medication because I don't think it's necessarily the forum here. If things are bad enough that you need to see a primary care doctor or a psychiatrist, absolutely do it. And when people think psychiatry, they often first think pills. What I want people to know is psychiatrists last think pills, but we have an economic structure that sort of pushes folks that way, and that's fine when they need them, and the medication can be extraordinarily helpful. But when we're just out living our lives and we're trying to figure out what to do to prevent depression, what we should do to treat it for ourselves, you can think of all the other things and let your doctor worry about that, and when they talk about it with you. So you can invest in all the other things before you come in to talk to us, and then we can suggest a medication if and when it's necessary. So the last piece here, when I think health, this is what I think. COVID shut all of that down. This is a camp in Kings Mountain, South Carolina. My kids are 19 and 17. They started going to this camp when they were really little, and now they're both counselors at the camp. And there is nothing better for their mental health than when they take final exams, and my wife and I get them off to camp, and they spend the entire summer helping these younger kids have the great experience that they had. And you can see it here, right? They care about each other. They're sharing experiences. They're outside. They're getting natural sunlight. They're exercising. There's somebody controlling the food that comes in and out. So they're constantly eating fruits and vegetables and checking in with each other and having a lot of fun together, right? So ideally, no, we can't all live at summer camp. But I thought this would be a nice picture to kind of drive home the point that there are things we can be doing for each other and for ourselves that do work, that do prevent depression, that do treat depression. And if those things don't work, Providence, the health system Providence, is always working on delivering, developing, deploying new ways to treat your illness. And we're more than happy to help you if you show up in one of our clinics or our emergency room. We're here for you. And thank you so much for joining today. Thanks for everybody at the Providence Health System for inviting us. It was enjoyable to be a part of this. Thank you.
Let's give another round of applause for Dr. Harman. Geez, wonderful job. Thank you so much. Yeah, Dr. Harman, I've had afforded the ability early on in my career here at Providence to work side by side with Dr. Harman, and I've just learned so much and continue to learn so much in the field of psychiatry and how to treat folks experiencing any sort of psychiatric emergency. So thank you so much, Dr. Harman. I look forward to many more years learning from you. So thank you guys for your instant messages. We had a couple come through so far. This one here is going to be directed, looks like, for Dr. Pisano. So we had one of our viewers, Dr. Pisano, had a question specific to the types of addiction that we treat at our recovery center.
So the classic addictions that we treat are, at the recovery center are principally substance-based. So, so we treat, and the addictions are usually kind of like what I was talking about, the stimulant drugs, which usually tend to be cocaine and methamphetamine, alcohol, which is still number one, even though a lot of the other drugs get more press. Prescription drugs. So the prescription drugs are in two classes. One would be the benzodiazepines. I talked about those. As I talked about those amino acids that help relax your brain. Those drugs are very addictive, and withdrawing from those drugs is actually more dangerous than withdrawing from a lot of other drugs. And then the last class would be the opiate drugs, whether they are prescribed or illicit. So we don't treat behavioral addictions, even though they kind of all involve the same pathway. So our focus is on substance-induced addictions. So I'm not sure if that answers, if they have a specific question about a specific medication or drug, I'd be glad to answer that. But usually it's a substance, and the substance causes the cycle of addiction. So what is the cycle of addiction? You use drugs, you feel good for a period of time, you stop using the drugs, you start feeling poorly and badly, so then you continue to use those drugs again. And then kind of what happens in that cycle is what people who are either in the community treating the people who are on this call, the patients themselves who may be on this Zoom meeting, or the more than likely the significant others. So the negative consequences, the damages to their health, to their lives, and no matter how big they may be. And everybody, we talk about hitting bottom. What is hitting bottom? Hitting bottom is that low. That low doesn't always have to be you end up in the streets, or you end up dead, or you end up hopeless. And hopefully people don't have to get to that place before they seek help and get treatment.
Dr. Pisano, thank you so much. Yeah, like you said, I hope that answered your question. Really quick, just some housekeeping issues. So right now we've actually posted up a link. We're going to ask that if everybody could take a few minutes to answer the poll that you see appear on the screen. Give your honest feedback. We would greatly appreciate it, and we would like to know how we can improve upon these lectures moving forward. So we'll continue. We have a few more minutes, so we're going to go ahead and answer a few more questions. Reminders that the Q&A there on your tab go ahead and put any questions you have for any of our physicians, so we can go ahead and answer those. So we had another question pop up that was specific for our inpatient and our outpatient. I can kind of jump on that. Or Dr. Pisano, would you like to talk probably for the recovery?
So the question would be specifically to what are the programs that we utilize or treat both as an inpatient and an outpatient?
Sure.
So we have all three levels of care, and they're all different, and they're all defined principally by insurance companies and by standards. So the highest level of care is what we provide at San Pedro Hospital, which is acute inpatient, and it's usually called detox. That's usually a limited period of time, usually 3 to 5 days, can be up to 7, can be as little as 2. And so that's where you need medical and nursing care around the clock. The next step is something called acute inpatient rehabilitation that we provide, but a lot of insurance companies realize that after someone's been safely detoxed, they can go to a level of care that's slightly lower, that's called residential care, where you don't have to have a doctor and nurse available 24/7. And then outpatient, we do have an outpatient program. Our program is not as robust as it used to be, but it's a Monday, Wednesday, Friday program. It's tailored more toward the senior group, but we want to expand it and get that going again. So the levels of care are inpatient treatment, residential intensive inpatient rehab, which is a slightly different definition. Something that's more common that people probably know about, which is residential treatment. So a lot of the treatment centers that people are very well familiar with, where people live and you have counselors, you don't always have the nursing care and the doctoring care, but those residential treatment programs are pretty much all over the place. So all the programs that you've heard or read about or seen on TV are usually residential treatment. And then outpatient treatment is the most common treatment. And like I said, statistically, it doesn't matter which level you start at or which level you do. What matters is that you embrace recovery. And in a sense, you have to be brainwashed, because you got to realize that once a person stops talking recovery and making recovery the absolute #1 priority in their life, they're going to relapse, because you can't start that car with a dead battery, and the only way you can keep that car running or going is to push it. Now, if you have help and you have a program behind you, then your chances of doing that are less. So that's why relapse is so common. That's why that support in the first year is so common, and that's why we encourage a conscious commitment in that first, especially 90 days, but really a year.
Great. Thank you so much. Dr. Paisano, another one's come through the pipe here for you. So they're asking here, how long will it take to treat toxification of alcohol withdrawal for our patients admitted to our hospital in San Pedro?
Alcohol withdrawal is usually, like I said, anywhere from 3 days is the average, can be as little as 2 and as much as 5. So usually it's short, and usually what we're doing is we're using medications to help prevent the serious reactions of withdrawal, which are hallucinations, seizures, and then it takes, and those are usually handled within that period of time.
Perfect. And then the other part question was, it looks like, are they safe to discharge once they're, I think what the question is asking is, once you've cleared them from detoxification, they've met their allotted time, you feel they're safe to discharge. Would it be safer for them to go discharge home, or should they continue in our CDU?
They're medically safe in that they won't have the negative consequences of withdrawal, but they're still very vulnerable. So we always recommend that they seek the highest level of care that they can afford, whether that's at our program, whether that's at an outpatient program, whether there's that as a residential treatment program. So So that the answer is maybe that's not I sound like a politician. Jesus, I've been watching too much CNN. No, it's not a straightforward answer, but the answer is they need as much support as they can get, and they need as much sobriety as they can get, because I'm sure people out there know and have experienced that with all the support and with all the love and all the finances, people still don't accept it and go out and relapse again. So
Perfect.
there's no one answer. It's you do the most you can with what you have.
Perfect. Okay, thank you so much. And it looks like another one's come through, making mention of some statistics. They quoted a report that said 13% of Americans reported starting or increasing substance abuse as a way as coping with direct stress related to COVID-19 and the stay-at-home orders. Would you say that that's pretty accurate with COVID and the stay-at-home orders, that a good portion of people started maybe for the first time or picked back up?
I think you got to realize that the disease of addiction is a genetic disease, and I didn't talk about that. That if you are the parent, if you are a child of an alcoholic, your chances. The statistics on alcohol and addiction is that 1 in 10 Americans is an alcoholic or an addict, and that means that about 10% of our society is alcoholic addict. If you have a parent who is an alcoholic addict, it goes up to about 1 in 4. So I think there's no right answer. I think 13% is probably a real number, that people did use more alcohol and drugs. Now, what's chicken and what's egg? I like to tell patients you can't tell what's chicken and egg when you're dealing with scrambled eggs, and that's what we're dealing when we're dealing with drugs and alcohol. And I think that as a society, we had to make some very difficult choices to help us deal with a once in a lifetime, once in a millennial occurrence, which was COVID, which was difficult for everybody. And I think that people using substances as an ability to cope is a reality. But, it really realizes what we have to do is that we have to be examples of that. You don't solve problems with drug and alcohol. You solve them by dealing with the problems. You solve them by talking about problems. You solve them by being around people that care about you and that can help you deal with those things. So it's a very complex issue. A lot of things happened with COVID, and I think one of the things that I hear from my old time patients who have lots of sobriety and didn't use Zoom is that they utilize Zoom and as a way to connect with people and other alcoholics and addicts all over the world. And they, people who never turned on a computer in their life or never turned on a laptop were going to meetings and sharing and continuing their sobriety. But it's a struggle. It's been a struggle for all of us. This has been a year that is going to cause very significant consequences to a lot of people. The people who drank, the children of the people who didn't drink, and we're just gonna have to do what we best, which is what the 12-step program helps you to do, is deal with things one day at a time, accept the things that you can't control. So we can't control what happened, but we can control and be the best people that we can be, one day at a time, every day, be the best person you can be. And by doing that, we'll be able to deal with the kids who lost school, who lost a significant part of their growth and identity, and they will have losses, but we just have to deal and cope with them.
Well, thank you so much, Dr. Pisano, Dr. Harmon. This wraps up our lecture. I'm so sorry we've hit our time. In fact, we're a little over. So to be respectful to everybody's time, I'll read off on this and then we'll close. I just want to thank both physicians again. Thank you so much. Thank you to our viewers that did chime in and listen and ask questions. We sure appreciate it. As you saw, both Dr. Harmon and Dr. Pisano have their lab coats on and their scrubs on. They're seeing patients, and so they still made time for this lecture. So I can't thank you guys both enough for doing that. Just an FYI to the group, we will be sending the recording of this presentation to all the attendees who signed up. We'll also be posting it on our Facebook page for everyone to view at a later time. You could find us at Little Company of Mary South Bay on our Facebook page. For any additional information or to schedule a physician's appointment, please call our Patient Engagement Center, and that number is going to be 1-888-HEALING. Again, that number is 1-888-HEALING. Thank you again, and please enjoy the rest of your night.